Good afternoon and welcome to our second presentation of the Maryland DHMH Billing Manual. Hemi Patel and myself, Chris Perky, will be presenting the webinar today. Just a few housekeeping tips before we get started. You should have all received several documents when you received the invitation to the webinar. Table of contents, how to navigate through Adobe Portfolio, and also information about how to locate the webinar. I will let you know that the 322 webinar that was recorded and the updated manual, which is version 2, date 4/10/17, has not been posted yet on the DHMH website, but it will be posted soon, along with this webinar, which is being recorded. You, the audience, has been muted for the duration of the webinar, but we welcome any questions. Please type your questions in the display box, and we will try to answer them at the end of each chapter. Or you can always forward your questions to us via email. Today we will cover Chapter 5, Billing-Related Software. We ran out of time during the last webinar and promised to go over it again, so we will review it like today. Chapter 6, Maryland Insurance Payers. Chapter 7, Contracting and Credentialing. Chapter 8, Compliance. And Chapter 9, Additional Resources. As mentioned during the last webinar, we are planning to do a 4-hour on-site training session to cover Chapter 4. Chapter 4 covers each of the LHD programs individually, such as STI, HIV, immunizations, and school-based health systems. We anticipate the on-site training session will take place sometime in May, and we will keep you posted. For the benefit of those who are unable to attend the last webinar, we will briefly go over how to navigate through Adobe Portfolio and why we chose this format. Now, Henrik will get started.
So before we get into the chapters and into more detail, we would like to show everyone how to navigate around the portfolio. In summary, the reason we chose the portfolio again was the ease of being able to update and really search through this large document. We have on the top right here a search bar, which allows us to easily search different parts of the manual by just typing in a word here. We can briefly go over an example. So if we type in COMAR in the search bar and click enter, the search option searches through the entire portfolio and finds different instances where COMAR is found. And we can then look at the different instances that have been pulled and double click, and it'll take you right to where COMAR is and the different chapters that COMAR is found within. So it makes it very intuitive and again easy to use because of the search function in the portfolio. Also within the portfolio, another feature that we wanted to show everyone was the ability to download files and chapters. If you look on the folder here, there's a downward arrow saying extract folder. Pressing that button allows you to download all of the chapters within the specific folder. If you double click on the folder, you see all these documents and different subchapters. Each of the documents, when are double clicked, there's another extract file option. This allows you to download the file, the individual file, to your desktop, which can then be printed and shared with the rest of your team. Some of the documents also have URL links. These URL links are valid. We've double-checked them. They're all up to date. And double-clicking on these links allows you to open the link into the Internet Explorer. And we'll show you an example of opening that up.
So if you open up the document and you double-click it, because it's in a PDF in the Adobe Portfolio, it opens up the document, and all you have to do is hover over, click it, it will open up your browser, and it will appear on your computer. And the reason why we did this was so we could make sure that you had the most updated information of all times, because a lot of the information, as soon as you publish the manual, has changed. And that's one reason why also we're using version 2, which you will have access to, because we've updated things with the 2017. Okay, get back to the manual.
So we'll get into the chapters at this point. We left off last time with the billing related software chapter, which is chapter 5 of the manual. We'll go into a little bit more detail than we were able to last time because of the time limitations that we had. The first document in this chapter goes over the different types of billing related software. As you can see, there's the practice management system, the electronic health record, the electronic medical record, the clearinghouse, any appointment and recall reminder systems, insurance eligibility verification systems, and Immunet. The practice management system, often referred to as PMS, the primary function of the PMS is to organize the practice's clinic, administrative functions, and revenue cycle functions. Some of these functions include appointment scheduling, capturing and maintaining the patient demographic information at check-in and insurance information, maintaining your CPT and ICD-10 codes, as well as maintaining and updating your fee schedules, maintaining a list of insurance payers for claim submission, and also performing a whole variety of different billing functions, including charge capture reconciliation, AR management, electronic and paper statements, and your administrative reports. Your electronic health record, the primary function of your EHR is to replace your paper medical charts and to improve patient outcomes, track and report data. This is your clinical record and everything outside of your practice management system and your administrative functions. Then you have your clearinghouse. The clearinghouse is your intermediary company that formats and forwards medical claims to payers and is best known for its claim management features. We'll go into a little bit more about clearinghouses in the following subchapters. Most clearinghouses have the ability to scrub your claim for missing or inaccurate billing codes, missing data, and payer-specific requirements. This really helps internally because it allows us to know what's clean and what's not in the claim, allowing us to make the appropriate changes before the claim goes out to the payer. Clearinghouse's software can be fully integrated into some PM systems, so claim and payer denials can come back directly into the PM system. And this allows you to track your denials and payer denials much easier when there is that integration. The next subchapter that we're going to go into is the first billing related software that we'll be talking about. That's the practice management system. We'll open that up. The practice management system, key features and functionality requirements. So this document really goes into more detail about the key features of a practice management system. Patient scheduling and management. So the practice management system, again, is where your appointment schedule is handled, where you want to make sure that it has the ability to double book, the ability to schedule by individual providers and by procedure groups. The ability to generate patient reminder calls. There are PM systems that can generate patient reminder calls, limiting, therefore, not having to have people make those reminder calls and allowing your system to generate those patient reminder calls. And then there's patient reminder calls via patient reminders via phone, via email, via text, and it's important to make sure that these different capabilities are permitted in your PM system.
Where this is helpful is like in immunizations, where besides doing patient reminder calls, you can do patient recall. So if you have a patient that is scheduled to have a series of hepatitis vaccines, you can put it in the system to say, and they don't schedule an appointment in 3 months, to be able to do a reminder to the patient that it's time for them to come back. It's a really nice feature, and again, usually they have your choice of whether you want to electronically send them something through an email, whether you want the system to call the patient or text the patient. And usually all that information is obtained by the patient when they're in check-in. They ask what preference it is for us, for you to contact them, either to remind them of a call, a recall, or a cancellation.
To go off what Chris said, also the ability to collect and store.
The ability to collect and store patient registration information, the demographic, insurance, to be able to scan and your insurance cards is really important. Also, it collects meaningful use data, and also you do photo IDs, referrals, and that type of thing in the practice management system. Some of the EMRs, EHRs, also have that capability if you don't have a practice management system. But typically, you have a practice management and an integrated EMR working together.
And with the super bill, the ability to create and update super bills, the ability to create and update multiple super bills, the ability to print individual super bills, the ability to print batch multiple super bills from the schedule, the ability to use an on-screen super bill, displays patient demographic and insurance information, something that indicates outstanding patient balances and if a copay is due, the ability to show messages, for example, bad debt, updating information, getting referrals.
So about the super bill, I know some of the health departments call them routing slips, encounter forms, super bills, there are various different fee slips. Basically, a super bill is what keeps all your codes on it, your most frequently used CPT codes, and sometimes some of your ICD-10 codes. The reason why you want to make sure a practice management system has the capability to print and create multiple ones is because the health departments have multiple programs. So the immunization super bill is done quite differently from the school-based or from the reproductive health or HIV clinics. Practice management systems also have claim management features, ability to generate paper claims or electronic claims, and real-time eligibility verification. They also have the ability to do product-specific claim edits. A lot of your practice management systems do. These are features that you're going to want to look if you're in the market to purchase a practice management system, to look for some of these features. That's mainly why we had them listed, so you'll know what your expectations can be.
We talked a little bit about claim scrubbing a little earlier ago, and the importance of claim scrubbing is it really allows us to take a closer look at your CPT codes, your ICD codes, missing data within the claim, and then most importantly, your payer-specific rules. So when scrubbing is done by your claims management part of your system, internally the changes can be made to make sure that when claims are being submitted, they're as clean as possible and compliant as well. Here we have a document that shows information on PracticeMate, which is a free practice management software. We aren't endorsing PracticeMate, but we did want to give this as an option to those of you that do not have an electronic medical record or practice management system in the health department. Different features of PracticeMate listed in the document. The benefits, of course, of free practice management software is there's no expensive hardware or software to purchase. There's no need to invest in expensive upgrades to take advantage of the latest program features. And all of the data is securely stored on Office Ally's network servers. So there is no need for daily backup of data. Office Ally is certified HIPAA compliant, which is very important. The cost, there are no monthly fees. There's no software to purchase. It's free setup and unlimited training via a phone support team. With PracticeMate, you are entitled to a free claim submission service, which allows you to send over 5,000 insurance companies claims to over 5,000 insurance companies free of charge. This system also allows you to look up patients, check patient eligibility, view claim history, reporting inventory, and searching codes to check the validity of ICD-10, place of service, and the modifier codes.
Now we move on to clearinghouse and functions. And Mick already went over a lot of the functions of what you can expect from a clearinghouse. One of the things, it is the intermediary filler between the practice management system and getting the claims out to the payers. You can do so many different things through the clearinghouse, but it's not always that you have to have a clearinghouse. You can go to your payers directly too. But this is basically an outline and common features of what the functionality of a good clearinghouse is. Like Hemick said, scrubbing the claims. There are some software systems, like Hemick also mentioned, that the clearinghouse will, the information from the clearinghouse, the denials, the reports, and things like that come over can get pulled right into your practice management system. Some of the practice management systems that don't have that feature, what you would do is go onto the internet and you would pull up your the clearinghouse portal and be able to pull up and obtain your reports and to be able to manage your claims that way instead of going through the practice management system. This is just a brochure that's put out by Navicure to explain what you should expect from a clearinghouse. It's a little bit more detail. You can take your your leisure. Just a little, like I said, just a little more information of what the outline was that I just gave you. This is also eligibility and benefit solutions that Indion puts out. Indion is now called Change Healthcare. It's been a clearinghouse that's been around for a long time. It used to be WebMD. So they have a lot of good features and abilities to be able to help you manage your claims also. Now we wanted to include Office Ally. Office Ally is a free clearinghouse, kind of like PracticeMate. The thing is, you need to realize with PracticeMate, Office Ally, and also Practice Fusion, which is a free EMR, there are limitations because it is free. One of those sometimes is reporting capabilities, which the health departments have a huge need to be able to report. So customization of these products are usually kind of a standard product that you have. It's got some great features. There are a lot of health departments that are using Office Ally. There's about 6 health departments that currently use Patagonia, and some of Patagonia also uses Office Ally. Because there's no charge, you don't have to pay physician claim submission charges, eligibility. Usually if there is a charge, it's very little with that. But claim submission, you're unlimited on how many claims that you can submit to the payers. So like I said, there are a couple health departments that are currently using Office Ally. They don't have practice management systems. So they log right onto Office Ally and they submit their claims directly that way. This is a little bit about the user manual. We included that for those health departments that are interested in looking into it or using it. And then this is the online claim entry instructions, just basically showing you how to navigate and put your claims in.
The next part is on the EHR and EMR. The first document that we have goes over the overview of the EHR. The electronic health record, previously known as the electronic medical record, received its first validation from the IOM report in 1991. We've listed some of the basic terminology that is involved in the electronic health record certification. This certification relates to a national effort to certify various requirements for electronic health record software. There is a committee that's tasked with determining what basic must-have features electronic health record systems contain in order to be certified. So when choosing your electronic health record, it would be important to keep in mind this certification committee and to make sure that the electronic health record system is certified by Certification Committee for Health Information Technology. The electronic health record, this term refers to computer software that physicians use to track all aspects of patient care. Typically, the broader term also encompasses the practice management functions of billing, scheduling. Electronic medical record, this is an older term, but it's still widely used. It has typically come to mean the actual clinical functions of the software, such as drug interaction, checking, allergy checking, encounter documentation, coding, and more. Your integrated EHR, this refers to the EHR that is integrated with practice management software. There are systems that have an electronic health record and practice management system integrated into one software. Typically, choices include purchasing a fully integrated product which performs all the functions of your practice management software, as well as your standalone EHR, which is compatible with the practice management system.
In the past, when practice management systems were the first to come out to do physician billing and organizational billing. But what happened was when electronic medical record came out to try to push providers to use that, often the systems weren't. They were two different systems from two different places. So the systems, what they did was write an interface so that some of the information, like demographic information, could be pulled over to the EMR, but they didn't share information. It wasn't bidirectional. So when you have a fully integrated EMR, EHR, the information is shared between the practice management billing piece and through the EMR. And a common thing would be your schedule. You could have a schedule that's maintained in the EMR, EHR, and you could have one in the practice management system. So when you're looking at systems, having a fully integrated system is extremely important.
The next document we have here goes over the different features and functions of an EHR. Before we get into the document, we have a link under the heading. The link takes you to the AIFP site that goes over the different features and functions as well of your electronic health record. Basic EHR functions: identifying and maintaining a patient record, managing patient demographics, manage problem lists, manage medication lists, manage patient history, manage clinical documents and notes, capture external clinical documents, present care plans, guidelines, and protocols, manage guidelines, protocols, and patient-specific care plans, and generate and record patient-specific instructions. So the electronic health record is really the clinical part, your clinical software, different from the practice management system that we talked about. And we definitely we're kind of stressing this distinction because a lot of times it's confused as being the same type of software, but it's very different in their functions. And here we've included a comprehensive cardiac guide that it's a great resource. It has a lot of the different functions and features of your electronic health record. And again, it's a great guide in when you pick your electronic health record system or how to maximize the use of a system that you may already have. Again, here it has different stages in planning and implementing EHR system, has a glossary of terms and different resources for selecting, implementing meaningful use and other different related.
And it also has a grid, I'm going to go down one more chart, that helps you when you're thinking about implementing an EMR, which is really, it's very helpful. And the last section on the billing software is being able to bill directly to the payers. Now, this is a way you can reduce some of your expense. We're finding that more and more the insurance companies want you to file your claims directly with them through their portals, their provider portals. So you can set this up with your practice management system. So instead of your claims going to the clearinghouse, they can be created in a file, and the file can go directly to the payer. Again, the turnaround time is really quick for denials, and usually your practice management system is going to do quite a few of the scrubbing anyway. But reimbursements are pretty quick also when you go directly to the payer rather than through the clearinghouse, which is still pretty quick. But anyway, the advantages for submitting claims directly to a payer is the ability to submit without needing a practice management system. So just like Office Ally, you can go directly on Office Ally and submit a claim, or you can go directly to United Healthcare's website, or even to the Medicaid, e-Medicaid, which we'll show you in a moment. The service is free. Many of the your practice management systems can be, like I just mentioned, set up to bypass the clearinghouse. It saves you money, faster claim processing and reimbursement, and it's a cost-effective option for a clinic or a health department or practice that only submits a few claims. This information is a little bit about how you can submit claims directly to Maryland Medicaid. This is what Maryland Medicaid, many of you have already seen this, to link to them. It's a place where you can check eligibility because of the EBS. It's also where you can, if you're set up, which you need to be set up with Medicaid to do this, that you can submit your claims directly through Medicaid. And we included a tutorial on how to do that, to do your claims. And there's 11 pages to that. I won't go into it. Feel free to play around with it. Medicare also has enrollment and claim submission guidelines on how you can submit claims directly to them. Up until about a year ago, there was still a dial-up for Medicare, and a lot of practice management systems were submitting it, through the telephone, which is really old way of doing it. But this goes into detail again on how to submit your claims directly to Medicare. Okay, now we just finished Chapter 5. If you have any questions, could you please submit them? At this point, I don't know of any of them that are using the free practice management software. I do know that there are several that's using Office Ally. There's also an EHR software that's free, which is called Practice Fusion, which is different than the practice management system. So so you'd have Practice Mate, Practice Fusion, and Office Ally, which all three are free products. But again, there are going to be limitations to what you can extract from them, especially reporting. The question that I just answered, I'm sorry, was which health departments are using the free PM software and which health departments are using the free clearinghouse. would be interesting to hear their experience. I don't know whether I should get their actual names out over the webinar, but we'll be glad to see if they have any problem sharing that. And what I've seen in the past is everybody's been open to share their information and their experiences so they can make it better for other health departments. Thank you for your question. Okay, now we're going to get into the payers in Maryland, and this is a very interesting chapter. The first one, which is the one that's going to affect the most health departments, is Maryland Medicaid and the Medicaid MCOs. So Maryland Medicaid has tasked most of its services to be provided to their patients by a health choice. And health choice is one of the MCOs. And here are the health choices that are currently in Maryland. When you open this particular page up, you can literally just click on it and go right to their website. This information we found right on the DHMH website, and we fixed it so the hyperlinks are here also. I will point out that University of Maryland Health Partners was the formal Riverside Health. When you go to their website, sometimes it has University of Maryland, other times you're still going to see Riverside Health because they haven't switched everything over yet. United Healthcare, the MCO product is United Healthcare MCO, the community plan. And this description just explains a little bit about what a managed care organization is. This manual is recently put out by the state of Maryland, and it's Medical Assistant Professional Service Provider Manual. It's excellent. It talks about NPI numbers, and it goes into all kinds of details, anything you really need to know about billing for Maryland Medicaid services. It's not just for health departments. This is for any provider that's in the state of Maryland. This manual is billing instructions that really go into the 1500 claim form, and it tells you where, depending on these specialties, how you're supposed to have certain things in certain boxes. This is an excellent resource. This is the most updated. I just checked it the other day. It was revised in 2015. Not a whole lot's changed evidently from that. Here is the billing encounter data. This is a little bit more information where you can send paper claims for Medicaid if you don't have the ability to submit claims electronically. And that's how it's downloaded. One thing that's very important to mention with Maryland Medicaid is there are certain designated services that are considered self-referral. And those services are listed here, and they have a manual that lists it all. It would be like some of your reproductive health, school-based health systems, wellness centers, the DES, which would fall into the HIV. There's a whole list of items. This is a brochure that Maryland Medicaid puts out to check eligibility online. I think everybody, all the health departments have that. This is a professional service schedule for January 2007. This lists your reimbursement along with explaining about modifiers. Again, it's a great billing tool along with the professional services manual. This is a copy. Some of the health departments haven't seen this. It depends on which county, I guess, to how often you will see patients come through from this. And this is the Maryland Medical Assistance Family Planning Program. We thought it would be important to include some information about that. This is information that really is specific to the reproductive health services. There are self-referral provisions. This is something that came out last November, and we wanted to include this here, and I believe it's also under the program for reproductive health when it comes to billing for Maryland Medicaid. These are the time restrictions on filing claims for Maryland Medicaid, time limit. This is the administrative contacts for Medicaid. And this is the provider agreement to participate in the Maryland Medicaid program. See, we have a lot here. And then this is the 2015 Maryland Medicaid Guide for School-Based Health Systems. This one really was updated in 2016, but the cover wasn't updated, so just so that you know that it is more current than it appears to be. Health choice plans, these are the ones that we just mentioned under Medicaid. Most patients have to sign up for an MCO within 30 days. If they're going on Healthcare Connection, Maryland Health Connection, they usually sign up right there at that time. Again, we have a list of how to contact each one of the MCOs. We have a copy of what all the MCO cards look like as of beginning of the year. There may be some different ones now, especially with Riverside. This is the MCO comparison sheet. Now this one's very difficult to see. When you go online, it's just small, it can be. But it's a wonderful tool. It gives you the name of the MCO. It also gives you the time of operation. It tells you the nurse hotline. It will tell you what counties that the MCO is servicing. So you'll know which ones. It really gives you a snapshot of where you want to, which payers you may want to contract or approach first. And some of the services that they offer. So it's in English and it's also given in Spanish. And this is updated on a regular basis. This is the Maryland Medicaid Health Choice contact information, along with being on the website, that contact information. And I won't go into every folder because we have so many, but in each one, this is a mayor group, and here's a quick reference guide which we included. This type of information is really helpful for your front desk people. It tells you, what they require for pre-certification, notification, where they can go for testing if you're sending it, and how to get a hold of the company and what they cover. So these guides, the quick reference guides, are very, very helpful. And then we also, attached copies of the provider manuals, the most updated ones that were available at the time that we put this manual together. It talks about the credentialing, it talks about billing, just about everything you need to know. Again, here's a copy of the Mayor Group insurance card. This is contact information for a Mayor Group. We try to be consistent and offer the same type of items in each one of the chapters. Over-the-counter pharmacy medications, which provider newsletters, we always encourage you to have someone in your office or health department get on the newsletter. They'll send it in email. They can scan it, and whatever information is pertinent to your clinic, it's very, very helpful to have. This is a case management provider referral form. These are the type of notifications that they send out occasionally. This one's telling you about their web portal. This is talking about hepatitis C coverage for medication and how we would go about getting approval for that so that they pay it. And then these, again, are just additional, what they require with the 25 modifier to bill. This is using a modifier and goes into more specific billing information. We also have JAI, which is primarily located in Baltimore City, Baltimore area. Again, this is going to have a provider manual for you, quick reference guides, prior authorization requirements. That's your quick reference guide. Data sheet, members' rights, case and disease management. Again, I'm not going to go into each one of these. You'll go into them as you need them. That's why they're a reference to them. Maryland's Physicians Care. I will tell you that one of the nice things about Maryland's Physicians Care is that when you contract with Maryland's Physicians Care, you don't have to have all your providers credentialed like you do with the other MCOs. They allow you to just contract under the health department. So it makes it a little bit quicker getting on board and contracting with them than it would be with your other MCOs that require that. So this manual is updated through January 2016. And again, it'll offer you a lot of information what you need to know. And here's a copy of their cards and what their requirements are. When you're under contract, there are certain things that you are obligated to do, and this kind of outlines those. Here's a claim submission guide for Maryland's Physicians Care. And they have newsletters, and this is a list of the provider reps. As of November, and that's the most current one that I can find. Okay, MedStar. Again, there's the same information for MedStar, their provider manual, and you will notice that most of the provider manuals, sections of it are identical, and that's because there are certain requirements that certain things they require and do under the state of Maryland. So they will be very similar, and all of them will have the same verbiage for your self-referral products. There's Priority Partners, which is under Hopkins. I will say when you credential with Priority Partners that they don't use DHMH, but you can print out the Maryland Credentialing Uniform form and submit that to them, and hopefully they'll accept that. Some of them have gotten them to accept the DHMH because it is very time consuming if you have to credential and fill out paperwork separately. So this is their provider manual. Again, we have their quick reference guide and their outpatient referral and pre-authorization guidelines. University of Maryland, which is the old Riverside, they still have the provider manual listed as Riverside, like I mentioned earlier, along with some of their other items. That will need to be updated as they transition. The United Healthcare Community Plan is probably one of the most, along with AmeriGroup and Maryland's Physicians Care, one that I see used very frequently in the health department. And United Community Plan, 13 of the 24 jurisdictions in Maryland became contracted with the community plan and with commercial products when they did a state contract. One thing I will mention about United is that they do, there's something that came up a few years ago, that they require an ET modifier. This is the form I'll show you. And I think most of the health departments are aware of this now. In order for you to get paid for your in-house lab test, like your wet mounts, if you did a stat strep or if you did a stat HIV test, urine dips, you would have to have an ET modifier attached to that particular lab code in order to get reimbursed from United Healthcare. That's the only insurance company that requires that. Again, this is additional information about what they offer to the patient. I know that was a lot of information, but now we have commercial payers, and we have United Healthcare, which their products for the commercial are different. Again, we have their manual, their new patient policies, United Healthcare is across the nation, so you want to make sure that when you're looking at products and you do a Google search or anything about United, that you're looking at the Mid-Atlantic products, not something that's on the west or the Midwest. And again, we have the ET modifier information here. It applies to the community plan. Care First is a payer that a lot of the health departments are still having difficulty contracting with, but more and more are getting contracted with them because it's the largest payer in Maryland. We attach copies of what the insurance cards look like, the different product lines, which can be very tricky. Some have out-of-network benefits, some don't. If you're not contract with them, chances are if they're going to pay anything at all, they probably will pay it to the patient and not to you, just to be aware of it. There's our policy and procedures. Again, the provider quick guide and the provider manual, which gives a lot of great information. Then we have Aetna. I won't go on a lot. Again, it's the same thing. Provider manual, products. The products have all their insurance cards in it listed, what they have, coverage for. If you're not contracted with the payer, again, your chances of getting reimbursed. The patient's deductibles and copays will be higher, and chances of getting reimbursed are very difficult, as most of you know. This is Cigna. Cigna doesn't have a big presence in Maryland, but it has enough that we wanted to include that. This is information about the Cigna. TRICARE, we only have one article on TRICARE, but we do have a lot of military in the state, so we wanted to include that. And EHP is a commercial product for Johns Hopkins, and we just decided we would include that too. Obviously, we couldn't include all the payers, but we tried to do the ones that are most prevalent. And the last of the payer groups is Medicare. And some of the health departments want to know, why do we need to contract with Medicare? Well, some of your patients are dual eligible, meaning they have Medicaid and Medicare. Medicare would be your primary payer to Medicaid. So if you're not enrolled in Medicare, you're not going to get paid by Medicaid in most cases. So what we included here was enrollment. PCOS is an online enrollment process for a provider to become in network with Medicare. Medicare has their own set of codes that don't coincide with a lot of the commercial payers. They use G codes, as you can, in the wellness exam and things like that. There's not going to be a lot of instances where you see Medicare patients, because primarily they're all over 65, but there are patients that are disabled, handicapped, that will have those. And they may come into some of your clinics. So that's the reason we wanted to include it. Again, here's enrollment and claim submission. The biggest thing with Medicare, of course, is your roster billing. And we were asked to make sure we put information about roster billing in the manual. And so we have a whole brochure from Medicare that explains how to roster bill. And you do not have to be in network, but you have to have an agreement with Medicare in order to be able to submit and get paid for your immunizations on the immunizations they allow. It's very limited. This is about Medicare remittance advice, what it looks like. Medicare requires that you download your remittance advices, that they're going to be all electronic payments or all electronic to your bank too. It's not something you're going to get paper checks for. This is Who Pays First. It's a very good document about when Medicare's primary or another payer is primary. It's something that's very helpful. And this is something that we see comes up a lot, 99211, which is the nurse visit. And Medicare has this nice little chart that helps you to be able to determine when it qualifies as a nurse visit. Meaning it doesn't have to be a physician or a nurse practitioner or PA. It could be an MA that's seeing the patient to do something, and you can charge for this visit. It's a very minimum visit, and there's certain requirements in order to be able to bill for that. And some clinics, all they have is nurses, so knowing when you can bill that in addition to what other services that you provide is very important. Medicare is also pretty strict about ABN, which is Advanced Beneficiary Notices. If you have a patient that comes in and there's something that you're doing that Medicare may not pay for, that's something that you need to have them sign an ABN. So the information about the ABN is in here. Your other payers are the same way. If you're contracted and there's something that sometimes they pay, sometimes they don't, depending on what the diagnosis is, you need to have them sign a waiver saying, I understand that it may or may not be covered. This is information about the ABN. Again, it sounds like we're probably getting too much into the private sector, but it seems like a lot of the health departments are expanding what their services are, and we want to make sure that you're prepared for them. We don't want you to get denials or any surprises. Okay, we finished chapter on Maryland payers. We have some questions here. Question 1. How can we submit claims directly through insurance companies' websites when most require indemnification clauses to sign up? That information we will go into a little bit with contracting and credentialing, which is the next chapter. Claire Pearson at the AG's office, when she worked out the details of United Healthcare and some of the commercial payers, how that the indemnification and also tort laws, how that applied with the commercial payers. So that is something that has come up when it comes to the contracting. The next one, Aetna, will be coming in October will be coming in October. I'm not sure. Okay, Aetna, well, we got information on Aetna, and we'll talk a little bit about contracting in a few minutes about the different commercial payers. The third question, will there be continued TA offered with the billing manual? We hope so. We're not sure. We're talking with DHMH about how they want to continue to update the manual and technical assistance. They're basically waiting for the health department to give them the information back. What do you need? Because they want to help you. That's very clearly the message we've gotten. So to find out, if we can find out what the health departments need, what assistance they want, we'll see what we can do to help them. Okay? Thank you for your questions. And now we're going to go on to contracting and credentialing.
All right, so we'll start the chapter on contracting and credentialing by going over the differences between the two. Sometimes the two are confused, contracting and credentialing. Sometimes people think they're the same thing, but there are distinct differences between contracting and credentialing. The credentialing piece of it is the process of organizing and verifying a provider's professional records. This is where the provider is credentialed on the contract that already exists. Their MPI, CAQH, professional licenses, diplomas, certifications, attestations, and professional references are documents that are used during the credentialing process. The process of credentialing is to verify the accuracy and specific data in a provider's documents. So again, this is really the second part of the whole credentialing process. Credentialing the provider itself does not make the provider in network. The contract has to be there. There has to be a contract between the organization and the payer in order for the provider to be credentialed under that contract. With that being said, the contracting piece is the process of applying for and setting up an agreement or contract with an insurance company to become in-network. The agreement and contract establishes and includes reimbursement rates, services that are covered under the contract, as well as payer and provider obligations. So the contracting piece is really the piece where fee schedules are established, but fee schedules really do exist in the contracting part of the credentialing process. Once the contracting part is complete, providers can be credentialed under that contract. So I know I've said that a few times, but it's important to really distinguish the contracting and credentialing piece. The last paragraph we have there, it summarizes what I just mentioned here. Contracting and credentialing is a completely separate process. Both processes must be successfully completed before an organization or provider is considered in network with the payer. Payers will notify an organization with the date their contract is effective. If services are provided to a patient prior to the effective date of the contract, the claim will be processed as out of network. Providers do receive notification from payers once their credentialing has been completed and approved via welcome letters stating that they're in network with the specific payer that they're credentialed with.
One problem that we've seen in our experience, Hemick and I, is that often a provider will get a notice saying you're credentialed with this payer, and then they'll start seeing the patients. But in all reality, because the contract hasn't been ratified and signed off on, they're really not effective under that particular organization. So just a little FYI, if you get new providers in, you want to be careful and make sure that before they start seeing patients that are under that insurance, even though you may have a United Healthcare contract that's ratified and effective, that doesn't mean that your provider is, and vice versa.
And that perfectly distinguishes the differences between contracting and credentialing, that the provider has to be credentialed under an existing contract that is in place between the organization and the payer. The second...
Sorry, I jumped ahead too far. Here we go.
So this is a nice flow chart that really goes over the entire credentialing process from start to end. We kind of did talk about it in the previous document that the agency contracts a health plan for network participation. This is the organization contacting the payer saying that we want to be in network with your insurance company. Is credentialing required? If so, the appropriate application information is gathered from CAQH, and that application is submitted. And CAQH is your provider information data source that really houses all of the information that we talked about earlier, your MPI information, your license information, all of the provider information that's needed for credentialing. Once the application is submitted, CAQH verifies the credentials, and then that is sent over to the payer for committee review. Backing up to the previous step here, if credentialing is not required, the agency just follows the typical contracting process.
And right now, it would be Maryland Medicaid, straight Maryland Medicaid. They expect that the health departments are going to track their own providers' credentialing, and Maryland's Physicians Care. Those are the only two that don't require actual credentialing of the providers at this time. And then, like we mentioned, Johns Hopkins may not use CAQH. So
this tool here really can be helpful for someone internally that's handling the credentialing, because it really does delineate the steps in the credentialing process and where things are handed off between the payer and the organization.
it gets very confusing to people if they're not used to the credentialing world or the contracting world.
Here we have a little more information on CAQH and CAQH ProView, where this is where formerly known as the Universal Provider Data Source. The CAQH ProView is again where the information is entered in, where the provider information is entered in. We've included a link under the heading that takes you straight to the ProView site and goes over how to register, how to sign, how to fill out the application, and to create an account. So it's, again, very intuitive, and all the information that you need to complete the CAQH application is in this document and in the link. Below here, you see a sign-in link. This allows you to, if you click on the link here, it'll take you directly to the CAQH ProView. If you're already an existing user, it'll allow you to sign in right away.
What happens is typically the practice administrator, manager, or somebody in fiscal will actually go in and sign up as a practice manager so they can enter all their organizational information. They can enter their tax ID, organizational MPI, when the clinic's open, et cetera, to set up basically the baseline. So when the providers go on to enter all their licensure and all their information, they link right to the organization. And what's nice about that is it saves the provider a lot of time entering all their demographic information. It does take a couple hours for the provider to do their credentialing, put all their information in CAQH, but it's a wonderful source. This list that they give, ahead of time lets the provider know what documents they're going to need in front of them for them to be able to complete it. They can start the application and then, stop and go back to it later. Once the application's filled out, until they get a notice from CAQH that it's been accepted, it's not ready for the payers to be able to access, to be able to do the credentialing, because the credentialing part is done by each one of the payers separately. Unfortunately, it's not done at one time, and then everybody piggybacks on it. So the provider, they have to get permission for which insurance companies can have access to the information, but they have to make sure that the application's ready. And they will get quarterly notifications, the providers will, that they have to reattest that their information is correct.
And here there are several videos that go over how to upload documents such as the provider license, provider certifications into CAQH, which is required for credentialing. But there are videos on how to do different things within CAQH for those of you that have not gone into the CAQH ProView yet.
And what's nice is it reminds the providers when their license is coming up for renewal, or when their DEA or controlled substances. So that's really a nice feature of it, and it's free.
Here we have a provider quick reference guide on CAQH ProView. Again, it's more information on the ProView, how to register, how to fill out the application, and what you'll need to get started, the different documents that are needed in the process, the provider resume, medical license, DEA certificate, CDS certificate, W-9, malpractice, and a summary of any pending or settled malpractice cases. So really does go over what's needed for the CAQH ProView completion and the types of documents that are. And
the providers only need to sign, they'll get a unique CAQH number, and they only need to fill it out one time. So if they're working for different organizations or working at multiple health departments with different tax IDs and all, they don't need to do this each time. There's a place in there that'll link them, to the information, because your contracts under a different health department will be different and paid differently. Mm-hmm. So they take care of all that for you.
And you see here, for new users, providers using this solution for the first time, that's the CAQH ProView, this should allow approximately 2 hours to complete the process. So it is relatively a lengthier process in order to make sure that it's completed thoroughly and comprehensively, and all the appropriate documents are uploaded into the portal. And again here, this is a provider user guide that's pulled from CAQH ProView. Very comprehensive, just more information on how to use ProView. We've included a link directly to the CAQH ProView in the previous document. We tried to summarize the information that's in this user guide in the previous document, and here is the entire provider user guide for those of you that wanted to skim through it. There's a lot of great information in here to make the process easier, and the less errors that are here, the faster the credentialing process really does occur.
And just remember, like I mentioned before, any new provider that you have, nurse practitioner or physician, needs to go through this process if you want them contracted. PAs, physician's assistants, some of the payers are now requiring some credentialing, but up until this point, most of them, the PAs were billing under the managing physician, so to speak, under the supervision. So those are things that are payer specific, that when you go to contracts, you need to find out which physician extenders they allow and which ones they don't. This came into play with one health department that happened to have a PA. They didn't have a physician or a nurse practitioner at the time, so they couldn't get contracted because they only had a PA. So just to let you know why it's important. Okay, this is the part that we were talking about a few minutes ago about the Attorney General's office in 2014 created a protocol, the Secretary's approval, on what to do as far as contracting. And so we, I haven't read this whole thing through in a few years, but we included the documents. We talked to DHMH, wanted to know what we should include because we knew that this would be an issue. But Claire Pearson, the AG's office, had worked out some of the issues with the indemnification and the tort laws. So this document goes through the protocols. Here's another one. This is medical assistants, their agreement to participate. This is a document that was prepared for the health choice providers, for the managed care, like the Mayor Group and United Healthcare Community Plan. This was an amendment that Claire and the AG's office had put together in order for the health department to be able to contract with the MCOs. Claire had met with all the MCOs, and supposedly all the new contracts are supposed to have this language in it, but just in case, we included it, and we were advised to put everything in, so we wanted to include it. Last year, when Dr. Happ came on board and Dan Mitchell were on board, they came up with this memo about how the contract. At one point, they wanted all the health departments, once they got in the contract, before it was ratified, that they get it approved through the Secretary. This is something that was put out, like I said, in 2016 about addressing that. We're told we're going to have more specific and updated information from DHMH, but right now, this is what we have, and we were asked to include it all. So that's how I think here. And hopefully that will be a good guide for you. The last item in this chapter, a little bit about ECPs, Essential Care Providers. But the buzzword when the ACA, the Affordable Care Act, came, that there were designated people that became designated for essential care because their community needed somebody that designation, so that every one of the MCOs and all knew they had to have a quota, so many that would provide services to patients that were underserved. So the health departments were not part of the ECA designation sites, but in January 2016 they did get that designation, and hopefully it will help you with being able to contract with some of the payers in your community. We have heard that some of the payers have given some of the health departments a difficult time about contracting, so hopefully that designation will give you a little bit of leverage. Okay, so we've just ended chapter 7, and we have a couple questions.
Can you repeat the training information that is occurring in May? So there was a chapter in the manual that we've not covered, and we won't be covering in today's webinar. It's chapter 4, which is the LHD programs and services. This chapter really goes into more detail in regard to the specific programs and the different services that the local health departments offer. And we will be presenting and training that information in the training seminar in May. So all of the information except for Chapter 4 is covered in the webinars, so Chapter 4 will be an in-person on-site training.
What we'll try to do is, since we're covering HIV, PrEP, reproductive health, STI, we'll take and designate time slots. So I don't think somebody that wants to come in for school-based health system wants to listen to STI, but they may, or rabies. So we're going to try to budget, fix our time so we'll know how long. Each one of those, we do go into a deep dive about that particular program. I'm just going to show you real quick what that chapter looks like. And you're free to go and navigate around in the program, in the manual, and look yourself. But like the HIV, these are all the documents that we contain about HIV. And we will go into a little bit deeper dive with each one of those. So because they're unique, some of the requirements, when you get into reproductive health, you have Title 10 issues. When you go to school-based, you have other issues. Immunizations is different. So we can do a little bit more with the coding. We're going to have a coding specialist there that can actually go a little bit more coding and tell you. So that DHMH, and we felt that that was something that needed a little bit more attention and more time. Okay?
Thank you for that question. We'll move on to the
next question. Sorry, it will be an MCO in October. That is something I wasn't aware of. There's always, that's why I keep surfing the internet trying to find things. But what we will do, if we're managing the manual or somebody else's, they really need to put that information, update the manual as soon as it's available. Like I showed you, Riverside is transitioning, University of Maryland, they still don't have everything up to par. So hopefully we'll hear more about that as soon as, as it's available. Okay. Sorry, I missed compliance. All right, this is not my favorite subject, I guess. All right, DHMH has its own policy on compliance, which covers HIPAA, and which is privacy and regulatory and billing issues. So we're not going to go a lot into this because it's there, it's published. Each one of your health departments should have this and should have addressed the corporate compliance, the DHMH has put out. We also included the OIG's Federal Register, which talks about compliance and billing compliance. As you're getting more and more into billing, you're leaving yourself open more and more to audits. And so you really need, even though it's not a requirement to have a billing compliance plan, I always recommend that you do. How you're doing things. And several of the health departments have actually done their policy and procedures and outlined how they're going to handle if something happens with patient hardship, how they're going to handle if there's bad checks, how they're going to handle, just like you have CCU, the Central Collections Unit, what their guidelines are. That's part of your policy too, dictated by the state, but it's there. So everyone knows you're trying to do everything you can to avoid fraud and abuse. And that's the purpose of having a compliance manual for billing.
All right. Here we have information on HIPAA security and privacy. With the type of information that we're dealing with, patient information, it's important to protect ourselves from any HIPAA breaches. With employees having access to not only internal and external systems, it's important to maintain organized processes for providing accesses upon hire and deactivating accesses of termination. We've included several guidelines here for the health departments to implement to ensure that they're protected against any HIPAA breaches moving forward. So to go over some of them here, assembling a list of all internal systems your company controls accesses to, such as your practice management system, your EMR, any accounting and payroll packages, your email systems, your network. So all those different types of systems that are in your organization, having that list allows you to be better organized and allows your managers to really ensure that those areas and the controls are in place to make sure that there's no violations of HIPAA with those systems. Assembling a list of all external systems your company accesses via the web or any other secure means. Brainstorming all the different external systems that your company may use and assembling that list is important, as you'll be surprised to find that if your maintenance staff quits, no one could log into your schedule to schedule your next inspection for your heating and cooling system. Now, that's just an example, but there are several different external systems, including your provider portals that are used, making sure that we're not violating HIPAA with internal and external systems is critical. Creating a user access checklist, which includes a checklist of all the systems you've collected above and places an employee name, hire date, and termination date. And this allows us to really know who has access to what system and when they were hired and when they were terminated. That way accesses have been given as well as removed, depending on if an employee is hired or terminated. When you have a new hire, creating a copy of the checklist and putting their name on it, record every system the new hire will access, file the completed checklist into their personal file. This again allows you to have documentation of what the new hire has access to in your organization.
So that when you have an exit interview, you can make sure that all their access has been terminated. Like Hemmick is saying, the external access would be like going to the United Healthcare portal, provider portal, patient portal, Medicaid, to be able to see eligibility. Personally, I've had experience with a huge hospital organization that I was doing the anesthesia, helping that anesthesia billing department. Had 2 employees leave, notified IT to make sure they didn't have access anymore, and 2 weeks later I find out they're still accessing the system, working for a private doctor to get information, demographic information off of a patient. On patients for billing purposes, but it was a HIPAA violation because they were going in through the hospital access, not going through that provider. So it's very important, because your risk management with HIPAA, that those things be done and tracked, because usually you don't even know what access most of your clients or your employees have because people coming and going.
And also when they're switching between departments in the health department, it's important to update this checklist that we've advised to create, because they may not need accesses to certain softwares or systems in their new department, and terminating that access and updating that checklist is also extremely important. Again, we talked about when an employee separates or is terminated, taking out this user access checklist from their file and immediately deactivating all the internal accounts and contact all the external parties to disable all the access to these external systems. These are, again, just different ways for us to ensure that we're not violating HIPAA and protecting ourselves from any HIPAA breaches moving forward. Keeping these records stored and formally maintained. Often these records are maintained by your accounting department, your HR department, sometimes by IT, and even sometimes just by your administrator or director internally. We're done with this chapter, so we'll take some questions.
Okay. There was one question a moment ago again about May. We're not sure when in May. We're thinking maybe mid-May. And then also where DHMH said they have a learning center. We're not sure exactly where it is. We will make sure that everybody that's on our email list that you've gotten invitations for will get a notification of that. The next question is, can local health departments access the manual now? Where is it housed? Yes, you can. And the website, I'll just say it. We did send that also with the notification about the webinar. It was one of the items that you got. It's http:// Maryland spelled out .gov/LHD billing. The manual is so large we can't email it. We had to actually get it to DHMH by Dropbox, and your IT department at DHMH is making it accessible. Again, the version that's on there now is version 1. What you're looking at now is version 2, because as Hemick and I were preparing for the webinar and we saw more up-to-date information, we kept plugging it in there. So, but they are in the process of posting that in the 322 webinar. How does the next question is, how does the sliding fee scale work with insurance companies? Do co-pays, deductibles put on the sliding fee scale? Is there anything in the manual regarding this? Yes, we do have some information on sliding fee scales. Sliding fee scales are supposed to be applied to the uninsured. Patients have contracts with their payers that they'll be responsible for their deductibles and co-pays. Now, being in a health department, you have a little bit of flexibility. You can do things for hardship, and that's something we can go in a little bit more detail, especially when we meet with the different programs in the health department. And the reason I say that is because Title 10 patients come in and they can have health insurance, but then you also put them on the sliding fee scale, and depending upon whether their financial responsibility is higher with their copay or with the sliding fee scale, you have to build in the least of the two, the lesser of the two. So different programs have different rules, so it's not something you can just blanket across. But typically when there's a sliding fee scale, it's for those patients that are uninsured, because the ones that are really Medicaid, in Maryland, there's no copays. In some states there are, but in Maryland there are no copays with medical services with Medicaid. I hope I answered that question, but it is in the manual too. We actually have the sliding fee scale in the manual. We had 2016, so we didn't see 2017. So we're going to go into that a little bit with the resources. The sliding fee scale, I believe, is right in here in the next chapter where our resources are. Okay. So what the resource chapter contains is some of the items that were in previous chapters, but it also has just additional ones, like the common medical billing acronyms that a lot of you may not be familiar with, but you hear people throwing around that are in the billing world. So this has 4 pages. So we try to put them together. Basically, we kind of consolidated it to include things that the local health department does and uses frequently, which are not in the billing world for other people, but in your world. Glossary of terms, again, that's a little bit different than the acronyms, just a description of what we mean, when we say allowable charge, fee schedules, balance billing. It's a nice resource. This is a little bit of information about the Healthcare Commission, about electronic pre-authorization. It's becoming an issue with some of the payers wanting authorizations and pre-authorizations for services. So this just gives you a little bit of information about that. A lot of them are becoming, the payers are allowing you to do it electronically. So this is an outline from the Maryland Health Commission regarding that issue. This is just, we thought it might be interesting for you to see just a summary of what the Affordable Care Act is. We know we're not sure where the government's going with this, but right now this is just a quick outline. You know, we've had questions when we've gone out to health departments about this. So this really gives a nice snapshot, so we thought we'd include that also. This is something that one of the health departments was kind enough to provide. This is the DHMH's record retention and disposal schedule. I know this has really not a whole lot to do with billing, except how long you have to keep some of your billing records, but we thought it was something that had, again, come up with the health department, and we thought it might be helpful for those who are interested in knowing those guidelines. Now, this is something that's also come up. With most practice management systems, ICD-10s are searchable within the fields for the providers because it's become the ICD-10, there's so many digits in it, it's so massive, and they want you to be specific that they've actually incorporated in most EMRs and practice management systems. But this is a free tool. And for the health departments that don't have access to a practice management EMR that has this feature, this is something you can put on the desktop of your computer, and easily you can search and you can find any ICD-10 code you want. It's kept up to date. It's excellent. A lot of people use it. Again, you can even crosswalk ICD-9 to ICD-10 if you want. And we can't express enough how specific the insurance companies are getting, requiring providers to make sure that their codes are as specific as possible, or they'll deny paying it because the code's not specific enough. So it's a nice tool to have. Again, this is the ECP designation for health departments. This is what Heming was just going over a few minutes ago about HIPAA security and privacy. Again, we decided to put it in this section too, in case you didn't know where to go for it. This talks about 10 common medical billing mistakes that cause claim denials. Again, we got this from this location. You can go there and get more details, but claims not specific enough, which is what I just mentioned, the ICD-10, you're missing information. Claims not filed on time, timely filing. Just to mention on timely filing, Medicaid and Medicare allow 12 months for filing claims from the initial date of service. But the NCO payers, they only allow 6 months. So if you submit a claim that date of service is older than 6 months, they are not going to pay you. The other thing to note is that once you submit a claim, then the clock changes. And so you may have 6 months to submit a claim by date of service, but if you submitted it and they reject it, then your window of time to refile it as an appeal may be 60 or 90 days. So then you don't really even have 6 months from the date of service. So again, be aware of what the payers require during their contracts, and understand that even if you don't have a contract, they still have those restrictions. So incorrect patient identifier, coding issues, those are all very common billing errors that get your claims denied. This was something that's come up with a lot of the health departments about time-based coding. And the reason I mentioned it is because some of the clinics, like STIs, sometimes even family planning, when patients come in, they're not doing, the clinician spends a lot of time counseling and educating and talking to the patient, but not necessarily reviewing the system and exam. So time-based coding may be a way for those providers to bill to be able to get paid for their services, but there's very strict guidelines on how it has to be documented. So I know when we've come out and we've done some coding training, it's come up, and we should give them this little guide. But this is something I think will be very helpful if you're, curious about what qualifies for filing by time. This is another question that's come up quite a few times about 340B drug pricing. So we've got, we're able to find this little quick reference guide, and it gives you the information about 340B. And this is a little bit more information about 340B, the family committee. This is the uniform claim adjustment reasons. The reason we included this is because when you have a claim denied or there's a problem, they will take and give you a code. And there's a standard set of codes that Medicare puts out, but they don't have a comprehensive set. They just update it. So the core, which is Exchange, they maintain it, and it's through the Washington Publishing Company, and you can go online and to get those codes and the information. This is another one that another adjustment code resources. This is where I was talking about the Washington Publishing Company. This is the link, and you'll be able to click and go onto it. Some of the items have to be purchased. Some of it you can view. So we included that. This is the list of codes that United Healthcare has, the codes that are denied. And the reason why it's important to have codes is because when you go to report, in your running report, you want to see what your high rate of reasons that services weren't paid is to help you manage. This will give you that data, the statistics, and the information you need. So recording that whenever there's a denial or rejection is important. Okay. Are there any questions? Can you clarify, can we apply the sliding fee scale, the co-pays and deductibles to whichever amount is lower? That's only for family planning services. There's a Title 10 program that's applicable. Otherwise, the patient's responsible for their co-pays and their deductibles. Now, your health department can set up a hardship policy. It can't be across the board just saying that anybody that's income is this amount, you reduce it to this amount. What it has to be is looked at on a patient-by-patient basis. You have some pretty strict guidelines with CCU, the Central Collection Unit, and they give you guidelines on what's responsible. But it is also up to the health officer and how they want to manage those items. Okay. Are there any other questions? We would like to open it up at this time because we are done a little early. If there's any questions on any of the last webinar chapters that we covered, because we want to give you, since we have the time blocked off, we will go back to the beginning and just show you what chapters they are, and go ahead and submit your questions, and we will answer them. Otherwise, we'll end a little early. So, about Adobe, this is what we sent you. And the reason we sent you the chapters is so that when you go to search through the manual, if you look at the chapters, you might be able to go quickly to it, to where you want to go. So the first chapter we did was about Maryland general information, different county rules, map. The second chapter we did was creating the billing foundation, which is where we talked about NPI numbers and NDC numbers and poverty guidelines. Here's the sliding fee scale we talked about. And someone asked that question a little while ago. So this is the fiscal year 16 sliding fee scale. And you can find it here on the billing foundation. Here's the federal government. This is 2017, what their poverty levels are. And no questions have come in, so this is one more thing before we go. This is a revenue cycle management, and this is one of the most important pieces. This and the information about the individual programs when it comes to billing, this is very important. So the revenue cycle, what it looks like, what's involved with it. I mean, there are some great resources in here explaining the process of what a revenue cycle is. Okay. If there are no other questions, we will go ahead and end the webinar at this time. Just one more question. Okay. And the question comes up. How do NCOs determine if we are an office or a facility when we send the 1500 form? That's interesting because 4 years ago when I was working on the immunization project with Cleo Pearson, it came up and some of the payers said, oh, we don't want you to put in number 71, which is the code for, office code for the local health department. They only wanted you to put in code 11. And now that has a tendency to change. The place of service code, like for school-based health systems, it's 03. But they are looking at you as the health department now for the most part. Every one of the health departments I've talked to that have gotten contracts, they said that they're using that. So, oh, we have a nice thank you. So you did a good job. Well, thank you very much. And most of the information we've gotten is from you, from the health department. So you've given us quite an education. We hope you pulled it together for you. So if there's no other questions, then we're going to end the webinar now. You will be hearing from us soon about the May presentation. Thank you for attending.
Thank you very much, guys.